And we want to welcome everybody who is here to our last fall prevention awareness webinar of the month of September. We have two wonderful guest speakers that are volunteering their time to be here and tell you everything about health, health promotion and false awareness. So without further ado, I'm gonna go ahead and move on so that we can start giving the time to our speakers. Um, just give me 1 second so I can figure out which one is the slide. I have so many here. Okay, so our first guest speaker is Melissa Green. Melissa was born and raised in Utah County and completed undergrad at several schools throughout the state. She went to pharmacy school in North Carolina at Campbell University, then completed 2 years of residency in primary care and geriatrics at the Boise VA Medical Center. She joined the University of Utah after completing residency and has been a clinical pharmacist in the geriatric clinic for the past 5 years. So welcome, Melissa. I'll give the time over to you.
Sorry, I had myself muted. Thank you so much for having me today. I hope this is informative for you all, and I've kind of designed it to be a little bit of a discussion, so I hope that we can make that work through this. So we could potentially, if we can, unmute everyone. I don't know if people can do that on their own, or but hopefully there's a little bit of participation. So I work here in the geriatric clinic. I spend a lot of time reviewing patient medications, and one of the things I think we forget, can you advance to the next slide? Thanks. The overall impact of medications and managing them appropriately in an older adult population. I think these numbers are a little staggering to think about in terms of how medications really, like the overall impact of it. Medication-related errors are huge. It affects our healthcare expenditures, about 16% of the total expenditures, and it's $528 billion. It's a lot of money. And here you can see how it's broken down. I won't necessarily get into that. But today we're just going to talk about a very small portion of where we see some of this come from. It's medications related to falls. Falls are very impactful in this. They are a huge expense because when an older adult falls, it often will lead to a fracture and a hospitalization. Patients often don't end up getting back to their previous independent level. They may need additional assistance or assisted living facility or a skilled nursing facility. So this really is very relevant to trying to have an impact on this part of our society. Go ahead and go to the next slide. So today we're going to talk about medications and falls, the ones that are most associated with that, managing our medications and how we can help ourselves be more safe, some education points, and then also safety nets that can help us be as safe as we can in managing our medications. So next slide, please. Okay, so the first question I have for the group, what are some side effects of medications that you think would lead to or cause a fall?
Dizziness.
What was that? Sorry.
I said dizziness.
Dizziness. Okay, perfect. Oh, and people, you can, I didn't know there was a chat function, so feel free to use that as well.
I don't know how to, yeah.
Parallel dizziness is one.
You can also have drowsiness.
Yes, drowsiness is another one, right? If we're not quite aware of what we're doing or our surroundings, that can lead to falls. What else?
So a couple comments in the chat is low blood pressure and lightheadedness.
Perfect. Yeah. So if we've treated your blood pressure too much, then that can lead to some falls as well as just a feeling of lightheadedness. Good. Okay. All right. I'm going to put up the list here of the whole thing and we'll kind of talk about any that we've missed. Go ahead and click the down button again. It will bring up the list of, if you'll kind of like, yeah, there you go. Okay. So unsteadiness in walking. So, for example, if a person is in a hospital and they've been there for a while, we call it decondition, and become and feel more unsteady on their feet. So with that, we can do some physical therapy or direct interventions to try to improve that. Medications actually can also lead to your motor movement, so your muscles not responding as quickly. Or instead of motor movements, it actually can slow down your cognitive processing. So how quickly you're able to receive and interpret information to process your surroundings. So medications can affect that way and lead to falls. If it changes your vision, getting blurred or double vision, that can make it hard to interpret your surroundings and like where are the real boundaries of things that you have going on around you, rugs or stairs, where your shoes are. So changes in vision can lead to that. We've talked about the dizziness and lightheadedness. Some people call that wooziness, so that's there too. And faintness. So faintness can be a result of many different things, heart things, lung things, brain. So if a person is susceptible or at risk of fainting, then that can be a risk as well. And then drowsiness and tiredness. So, okay, Nick, can you advance it again? Okay, so the next question is, what kind of medications can lead to falls? Or what, I guess another way of asking this too is, what kind of medications do you think could potentially lead to these kinds of side effects? Blood pressure meds, yep, so that low blood pressure, if we do that, sleep aids, I see that one. Sleep aids is a very big one. Stimulants, not so much stimulants, but medications that depress the central nervous system, not so much as a stimulant, but the depressants definitely can lead to falls because they slow those processes down. When you slow the central nervous system down, you slow down the movements and you slow down that cognitive processing. Any other thoughts before we throw the rest of, or all of the list up there?
Also, 8013.
Finasteride, that one can have a risk of lowering your blood pressure, but it's not one that always does, so not so much. Okay, can we advance again? Yeah, perfect, thank you. So sleep aids I have up here. Sleep aids are a very, very big category here that increase our risk of falling. This includes over-the-counter medications and all prescription medications. Now, there are times that we do use the prescription ones, but it's with a discussion about the risks versus the benefits. But the non-sedative hypnotics like Ambien or Lunesta, they really are still associated with falling risk in older adults, as well as cognitive impairment that will increase the risk of those eventually as well. Over-the-counter sleep aids that people will take are like Unisom or Tylenol PM. The medication that's the PM component is basically Benadryl or something like it in its family called diphenhydramine or others like it. This medication has a very distinct side effect profile, and it's actually listed here as well. It's called anticholinergics. Medications with anticholinergic properties lead to a lot of problems in older adults. The ones that are kind of just annoying and can lead to problems down the road can cause constipation, dry eyes, dry mouth, can prevent you from being able to urinate. So kind of think of drying everything up. But the ones that become more concerning in older adults is it can lead to heart arrhythmias, cognitive impairment, and in and of itself, a risk of falling. It also changes vision too, so that's another reason and way it can contribute to falls. And these over-the-counter sleep aids are some of the medications that have the strongest of these anticholinergic properties. So they really are not safe medications for older adults to take. The one exception to that is melatonin. Melatonin is over the counter and can be safe to take for older adults. Other than that, though, anything for sleep should be discussed with a provider. Sedatives here I have listed otherwise from sleep aids because there are other sedatives that we use that when you are sedating a person increases the risk of falling. Benzodiazepines are the really big one here, and then other CNS depressants. Opioids are also a concern here because it can slow your movements down, and that can lead to falls as well. Antidepressants, antipsychotics, and anticonvulsants, they all can have an impact on blood pressure, and also they work directly in the brain. So anytime you have a medication that can get in and work in the brain, it can affect the CNS and lead to falls and changes that way. And then we've talked about blood pressure medicines and heart medications and how they can do that. So any questions about those medications or how they can lead to falling? Okay. Good. All right. Can we go to the next slide, please? These I also just like to mention because I don't think it's commonly known about how these factors affect your risk of falling. So the number of medications, just the count of the number of medications that you're taking is associated with falling. So the higher the number of medicines that you take, the increased risk of falling that you have. Also, for most of these medicines, the higher the dose is, the higher the risk of falling is as compared to a lower dose. And so sometimes some of the best we can do or the strategies that we use are to use the lowest effective dose of a medication that we possibly can. And then other things that we keep a close eye on are interactions with other medications, supplements and alternatives like herbal medicines. I think it's taken a little for granted that those types of products like supplements and alternative herbal medicines do have active components and they do interact with the same systems that medications do. And we have a lot less awareness and understanding about how the body actually processes those. And so there's a lot of unknown there about how medications and supplements and herbs can be interacting, and they can lead to these complications of falls and other changes in older adults. And then the other thing is sometimes like we want to use one medication for a certain disease but it may cause an impact or cause a problem with another chronic disease. So we also have to kind of keep the full history of the patient in mind. Go ahead and advance to the next slide. Okay, so what kind of tools can we, so one of the ways that we can help with managing the risk of our medications is to use some of these medication management tools. Can anyone think of what kinds of things those would be? Physician, yep. So your healthcare team pill container or pill box, perfect. List of meds and potential side effects, good. All right. Can you advance the slide? I'm going to speed up just a little bit to try to get through the slides. I don't want to take too much of your guys' time today. Okay, so these are just some of the tools. It's not an exhaustive list, but these ones are often quite helpful. Refill reminders or automated refills through the pharmacy, pill boxes. An alarm can be helpful either on your phone or one that you keep near your medications. Some pill boxes even come with alarms. So there's a lot of options there. And then one of the biggest tools or most effective tools in kind of keeping track of your medications and communicating information about medications to other people, your providers, a team, your others in your life, is this personal medication record. So go ahead and advance the slide. Yep, and then again, thank you. Okay, so what is a personal medication record? And what should we include in it? So someone earlier said a list of meds, yep, one to take. So that list of medications, we want every medication that is in your home on that list that you take all the time or sometimes, if it's an eye drop or a cream. So for that medicine list, we want everything on it. We can potentially list side effects again, maybe more so the warning or the things we should watch for.
I think you should list the generic name plus the prescribed name.
Yes, for some that's very helpful. For your medical team, they should be able to know both of it, but if you need to communicate to someone who may not have a medical background, that's very helpful to have both of those on there for sure. So that's good. Okay. All right, go ahead and advance the slide. We'll pull up the list here and we'll talk about them fairly quickly. So med name and dose. So as you said, Brent, both names can be very helpful to have. And then what the strength of the tablet or the cream or the eye drop, having that information in there. And then also, as I mentioned, you want all of your medications. So everything you take scheduled, everything you take as needed. Remember your eye drops, remember your medicated creams. You know, there's a lot of other routes that medications are administered. So we want to make sure we get all of those, plus the over-the-counter medications that you take as well. So anything that is any type of medication we want to try to have on that list. The other thing is instructions. Question here for you all, is it the instructions that are on the prescription, or is it how you're actually taking it? I see some smiles. So they should be the same thing, right? They should be the same, that the instructions are how you're actually taking it, but that's not always the case. So it really is actually helpful to know if you are taking it differently than prescribed, because then me as a pharmacist, what I would do is just make sure that there's not any timing interaction. So if you were taking it at a time that was different than it would be best used for. So there are even timing concerns that I would be looking at. And so it's really helpful to know exactly how you're taking your medication. It's also helpful to list the reason why you're taking medications. Some of our medications that we use, they have multiple purposes, and that's actually a good thing because we, if we can treat multiple things with one medication, that helps to keep your number count down. But for someone who may not know your history, they may not know exactly why you would be taking that medicine. So the reason or reasons why you're taking it is helpful to have on that list. Also, when you started the medication can be helpful. If you have allergies, include those on that medication list. And anytime you can give what the reaction was, that's really helpful. And a lot of times in the medical field, we'll list what the allergy is, the medication, and then in parentheses is what we put what the reaction was. So a common one with antibiotics is, we name the antibiotic and then in parentheses we say hives or welts or something like that to indicate what the problem was. And then just as kind of along the lines of the side effects, it's more so any pertinent warnings that you would want someone to know about your medications if they came across you and your medication list without any additional knowledge. So any specific instructions or concerns, that would be helpful to list. Go ahead and advance the slide. I'm going to ask them to make these slides available for all of you so you can use this as a tool to help put your personal medication record together. But here is a list of additional or optional information that could be really helpful for your provider or a pharmacist to have this information, but it's not necessarily the most important information to have on a medication list. It all kind of comes down to design and how small or condensed you're trying to get it to fit it into whatever you're going to carry. Because once you have your personal medication record, you really should have it with you all of the time. So I'll leave this there for you guys to use as a reference if you want to add any of this additional information on there. Go ahead and advance the slide. So these are just kind of a couple of education topics that I wanted to bring up with all of you. These are points that we don't necessarily discuss very often, but are very important and can be very helpful in staying safe with your medications. The first is ask your doctor and or pharmacist questions. Don't be afraid to ask them. And preparing questions for a visit in advance can be very helpful to help you remember what you wanted to talk with them about. And also potentially if you don't have time to talk about all of them, one, you can either give them the questions for them to maybe send you a message, or you can keep track of it to ask the next time you see the provider. I've listed here a bunch of questions that are related specifically to medications, but you can kind of take the same idea and apply it to your overall health and any of your chronic diseases that you would like to know and discuss in more detail than maybe you do with your provider currently. So you can kind of adapt these as well if you need to for your health conditions. But if you can know and understand these things about your medications, you can actually be one of your best advocates and be one of the tools that you can use to stay safe with your medications. If you can talk with your doctors about all of these factors of your medications, that you would have a really good insight into what the medication is and how to use it and everything you should know about it. Go ahead and advance the slide. Okay, and then just some other things are being aware of the potential side effects of medications. The most critical time often of a medication and the risk for side effects is when you first start it. But just know with any medication, a side effect can happen at any time. And in older adults, we have changes in our bodies that can actually lead to that happening. A lot of different properties in our body change as we age. And they continue to change through aging. And so it is not uncommon for older adults to become a lot more susceptible to the side effects of a medication and not necessarily as much of the benefit. And so that is something here that I keep in mind and try to keep track of and aware of. Ways that you can find out about side effects are your drug information handout that comes with the medication. Just realize with those, they list everything, like everything that has ever been discovered about that medication, not the things that are maybe the most common or would be more specific to you. So that is like kind of the most general and not helpful one, because you can't, it's hard to interpret what that means for you. There are some reputable websites that have good information about medications. So government websites, there are some medication related websites that are accredited through an organization that reviews those. It's called URAC. So if you find a URAC place, that's helpful. WebMD has some, and I think that is one that is URAC accredited. So it's reasonable to take information from that. Ultimately, I think the best source of information is probably your doctors and your pharmacist, so they can tailor the information to you, but that's not a bad site. And then health system websites like Mayo Clinic has some really good patient information, or even the University of Utah has quite a bit of information. So things like that come from a health system that were developed by healthcare providers are not a bad place to start either. And then, as I mentioned, working with your providers and pharmacists for information that's kind of specific to you. Okay, go ahead, next slide. You're on time. And then a couple of safety nets that I want to talk about, and I think this is one of the last slide. So some safe medication practices to know about, and this is not an exhaustive list, but ones that I come across quite often. I mentioned before, keep a copy of your personal medication record with you at all times. The other thing about that, though, is share it with someone who is close to you that would maybe be an emergency contact that could speak on your behalf. Can you go back to, yeah, thank you. Go back that you can give to someone who can speak for you in the event that you're not able to do that yourself. And one of those optional things that was on the list is who your emergency contact would be. So if emergency services sees that and have a phone number to call, then your emergency response person should also have a copy of that list. So that's also something to keep in mind. Also keeping that list very up to date. Even maybe putting the last updated date on the list is helpful. That helps us as healthcare providers know that, like, okay, this person is actively managing their list and it is up to date as of this, whatever time frame it is. Another key thing I see all the time that leads to errors is patients putting medications in bottles other than what they come in. And then it's hard, if there's ever any kind of question, it's hard to trace back to what that medication actually is. And then also being very intentional about managing your medications and having a specific process or plan for doing that. Everyone manages a little bit different. It entails a little bit different activities. But if you can develop that and stick with it and be consistent, that serves you well in the long run in developing really good habits. And then I always recommend a periodic clinical pharmacy or some kind of similar review to look at all of the medications comprehensively. And then another thing is utilizing one pharmacy whenever possible, because then the pharmacist there can help track all of the concerns and potential problems with the medication. It kind of creates a safety net outside of yourself, and if it's an outside pharmacy, then it also filters in. The other thing about that, so if it's not uncommon for older adults to have providers in multiple health systems that then don't share an electronic medical record that can communicate with each other well. And so as prescriptions get sent to the pharmacy, that pharmacy and pharmacist then are kind of where all of the information about medications comes to in one place, and they're trying to kind of help keep track of all of the potential problems with the medications and can inform the providers when there is one. Another safety net is really you yourself. You're the consistent factor in whatever your care team is. And so if you're able to understand and know your medications, you can communicate that to any of your healthcare providers. And then including a trusted family member or caregiver in that process is kind of your backup. So, all right, that is all I have. That was actually quite a lot of information in just a few slides. So if anyone has any questions, feel free to ask them in the chat here and I can take a question or two. But otherwise, I also have my email listed there and you can email me if you have questions. All right.
Okay, it doesn't sound like there are any questions, but we thank you for all this wonderful information that you've shared with us. And then if you want to reach out to Melissa, her email is right there on the screen. So, oh, hold on, Melissa.
Oh, sorry.
Go ahead.
I was just going to say, I'll hang around till the end of the talk. So if anyone thinks of anything, I'll be around at the end, but I will mute myself and probably put my mask back on.
Okay, thank you.
Thanks.
So we are going to go ahead and move on to our next speaker. She is already here waiting for us. So, but give me just a second here. Okay. And here he is. Okay. So, let me see. So, Lisa is here to join us today in this presentation. And Paige, why don't you go ahead?
So Lisa Ord is an associate professor of ophthalmology and visual sciences and director of the patient support program at the John A. Moran Eye Center. She has worked for all ages who have visual impairment. Welcome, Lisa. I know she was just on here.
I think she's having some technical.
Oh, okay.
Message saying she's frozen, so we'll just give her 1 second.
Oh, okay. Oh. That little triangle, it makes me so angry.
Maybe while we wait for Lisa to come back to us, do you guys have any comments or about our presentation that Melissa did for us? I'm sorry, Melissa. Could you call you?
No, you're good. I'm still here. So I am happy to take questions.
Or maybe if you want to put it on the chat. Lisa is gonna sign in again, so she is coming back in a second. No questions. They're a quiet bunch.
It's quite different doing this like through Zoom versus face to face. So I completely understand.
Yes.
I do think it's a good reminder about the list of medications because I don't take many, but if you take them for, like, I have asthma, so I don't think of ibuprofen. I mean, not ibuprofen, albuterol as a prescription drug that I take because I've just taken it for so long, and it's one of those things that if you make a list, you're like, oh yeah, that is a prescription medication. that to me is normal, but to somebody else, they need to know that I'm on albuterol and sure it affects my system. So that was a good reminder.
Yeah, no, that's great. And sometimes when people refer to medications, the ones you take by mouth are easy to remember. It's the ones that are often taken in different routes or different ways, or as needed medications. It just kind of slips people's minds at the time that they're asked that question. And so if you have that medication list, there's a couple of things that it facilitates. One, then there's some confidence that we've got a full list of your medications and we don't have to keep, you may not get asked as many questions. The other thing is it actually can speed up how quickly your provider is able to review your medications so that then you can start getting to the discussions about all of the other things that you have concerns about. So it can be really helpful in a lot of ways to facilitate that. It's a good point. Thank you, Paige. Someone asked a question about bubble packing, and I'll just briefly touch on that. So it really depends on the pharmacy and whether or not you have relationships. That bubble packing is actually called adherence. The overall term is called adherence packaging, and multiple pharmacies have some version of adherence packaging. It might not be like those bubble packs specifically. You just have to talk to the pharmacy and find one that you like, because there's quite a variation in that type of service. But a lot of them are free if you fill their prescriptions or for a minimal fee. So it just depends on the pharmacy. Okay, it looks like Lisa's trying to call in now instead. Any other questions? I can try to fill the time or the void.
I have a question.
Okay.
This is our last class of this, right?
I don't know that.
Is it? I thought it was just 4 weeks or this month.
Falls prevention is just the month of September, yes, but we will continue to have the webinars, but falls prevention is
okay,
just.
well, that's good. I couldn't tell from the, obviously I got confused with the advertising. But anyway, what I was going to ask in case it was our last, because I remember seeing this on some advertisement for the longer course in the past, was if you do trip and fall, let's say you trip on the sidewalk where the sidewalk isn't exactly smooth and you trip, which we all do, what's the best way to fall to be the safest?
That's a question for a physical therapist. I am not sure on that. I've had patients tell me that they've had training on falling, and I'm not sure what that training is. I've always wondered what it is, though.
We'll have Paige or Marianne pass that on to the powers that be. Okay.
Yeah, physical therapy would be good to talk about that. So, okay. It looks like Lisa might be on now. So okay. I will still stick around so I can answer questions at the end if anything comes up. But thanks. It was fun.
Lisa, are you here now?
On the phone, but I can see the videos or see the slides, so I think we're good. I'm so sorry about that. It was strange.
No, don't worry about it. Yes, don't worry about it. But we're happy to have you. So go ahead. The time is yours.
So let's go on to the first slide then. And perfect. So most of our sensory information does come from our visual system, and that is the system that gives us our sense of where we are in time and space, right? And the thing is that we think that everybody sees like we do, but we really don't know, do we? And there are natural changes that happen in our vision just as we age. These are things that happen to all of us just by having lots of birthdays. So our vision can help us to keep from falling, keep us safe. So some of the things you need to think about, general health practices that also help with our vision is nutrition, not smoking. Smoke, it really is bad for our vision. And then also, as we age and we have these changes, you know, just having some humility and patience with ourselves. So go on to the next slide. There we go. So this is a little diagram of the eye. And for this little teeny organ, we can slice it up into lots of little parts and have specialists that only specialize in one part of it. So this is looking towards the left, and the front part, what we call the anterior segment, that's the iris, the lens, the pupil. If you have cataracts, everybody will get cataracts if we live long enough. And we see an anterior or a cornea specialist for cataract surgery. Okay, so that's that white lens in the front. So they take that out and they actually can replace it with a prescription lens so that you don't need glasses because the prescription is right in there. Then we have the retina, which is the back of the eye. So this layer that goes around the back of the eyeball is our retina. And we have retina specialists, the retinologists. And they are there for people with retina problems such as macular degeneration, something that happens sometimes in older age as well. So then we have our optic disc going out to the brain with the optic nerve. And if you had glaucoma, so that's when the pressure in the eye is so high that it starts to pinch on that nerve. And when it pinches on that nerve, it actually can kill the nerve, and vision will dim and close in from the outside in. I'll show you a picture of what that looks like with somebody with glaucoma, and that's irreversible. Once the optic nerve has been damaged, it's irreversible. And then we also have people that specialize kind of in the center of the eye for the vitreous, which goes to the back, the uveitis for inflammation. Next slide. So we have two kinds of vision. We have our peripheral vision. This is like seen out of the side of your eye. It's a safety kind of thing. We see something that we might run into. We're not looking maybe directly at it, but we sense movement. We sense that there's something there out of our periphery. It's not the clearest vision, but it is definitely the part of our vision that keeps us safe. Next slide. Then our central vision. Our central vision is what we look at to see faces. So we look directly at someone, we see their face. We look directly at a book to read. So that is our sharpest visual acuity, the fine detail. That's where we're getting our contrast sensitivity. And the 20-20-20 rule is every 20 minutes you should look 20 feet in the distance for about 20 seconds, just to kind of keep from getting eye strain. So like if you're working on a computer, things like this, you want to make sure that you're doing the 20-20-20 rule. Next slide. So we've got our acuity, our visual acuity, seeing things sharply, but then we also have what we call the field of vision. How big is our field of vision? So a person with normal vision is going to have the part of the vision that is binocular, here in this circle. So what we see with both eyes. And then if you had only one eye, whether it was on the left or the right, that little 35% or 35 degrees of field is what you would be missing. So you can see that if you were missing an eye, if you only had one eye, you're not seeing exactly half of your vision, you're seeing more than that, okay? So, and then of course the blind area, that's, you know, I guess if you were like my mother and had eyes in the back of your head, that would be different, but that's the back of our heads that we don't have vision in. So our normal vertical field is about 60 degrees superior and 75 degrees here in the bottom, so we can see things without actually looking at them, so we don't trip over the dog that's at our feet. Next slide. But part of our vision actually comes from our brain as well. Our brain makes up things for us. So how many of you can see the triangle pointing upward? Okay. We see it because we expect to see it. It's not really there. You know, the circles, the 3 circles, have the indentation there as if it was there, but it's not really there. But we see it because we expect to see it. So our brain is filling that in for us. Next slide. So some of the diseases that will impact our functioning is macular degeneration, also known as age-related macular degeneration. If this happens when someone is younger, it's called something different called Stargardt's disease. But macular degeneration is also known as age-related macular degeneration because it's happening as we age. Diabetic retinopathy, glaucoma, and cataracts. Next slide. So I'll show you what some of these look like. So this is macular degeneration. And the picture on your left is kind of the beginnings. So people will say to me, I knew something was up when I looked at the door frame and it was kind of wavy. And I knew that it's not wavy, it's straight. So that's the distortion that you're getting in the back of this golfer picture. And then as it advances, you can see it starts to affect your central vision. So here they've got a big blind spot right in the center of their vision. That's macular degeneration. Okay, next slide. Diabetic retinopathy. So this is one of the best reasons, if you have diabetes, to make sure that you are taking care of yourself and keeping your sugars under control. So what happens with diabetic retinopathy is that the eyeball thinks that it needs more blood, and so it creates all these extra blood vessels that then leak because they're not quality blood vessels. And when they leak, they can get big blind spots that look almost like Swiss cheese. And you know, we can actually laser some of those little blood vessels so that they're not leaking, causing the blood vessels. But again, you're going to end up with scar tissue in the retina. So diabetic retinopathy, it can start to look like this Swiss cheese where you're missing parts of the picture. Next slide. So this is a picture of cataracts. So the left side, the circle, is what you know, somebody would say with 20/20 vision, which means, I'm not sure if you know what the visual acuity is. What that means is somebody with normal vision can see something at 20 feet away that is 20 feet away. So if you had 20/200 vision, you would have to, somebody like that would have 20 feet away in order to see what somebody with perfect vision would see at 200 feet away. So the left side is the 20/20 vision. The right side is what it starts to look like with cataracts. And cataracts can get so dense that it goes from being blurry to being totally blocked out. Cataracts are still the most prevalent blinding condition in the world just because many parts of the world don't have access to the eye surgery that we have access to here in the United States. So that's why it's still the #1 blinding condition, and it's totally treatable. A 15-minute surgery, inserting an implant, a lens implant, and you're done, and you see well again. So go on to the next slide. Let's talk about glaucoma. So glaucoma, that's when the pressure of the eye is pinching on that optic nerve. And when it pinches on that optic nerve, it starts to kill it. And you can see how the vision starts to darken and close in from the outside in. So this can get worse and worse and worse until there is no vision, what we call no light perception. That's the black vision. Most people who are blind have some vision. They're just either 20/200 in acuity or have less than a 20-degree visual field, and then they are legally blind. So that's what we call blindness. No light perception is the black blind, and a lot of people have this misconception about if you're blind, you don't see anything, and that's not exactly true. But in glaucoma, things start to wash out, and they start to close in from the outside. So you can imagine that if you have glaucoma and your vision is such as this picture, you're missing things and you may trip on something that's on the ground. You may run into something unless you're looking directly at it where your central vision is. Okay, let's go on to the next one. So also, those are the eye diseases, but just with aging, our eyes can change. First of all, we might need eyeglasses for reading, so reading glasses. That happens with age. Go on to the next slide. How many of you have dry eye? This is a very common thing, especially in Utah, because our environment is pretty dry. Well, it happens more as we age, and it also happens more in women than men. So our eyes are dry, but a lot of times, go ahead to the next one, even though they're dry, they seem to be watering. And it's like, how can I have dry eyes? They're watering all the time. And that's because the tears that are watering because your eyes are dry are not the quality tears that keep our eyes moisturized. So every time you blink with a dry eye, it kind of irritates the surface of your eye, and it starts to water. But those are not the nice lubricating drops that keep the eyeball moist. So that's why sometimes you'll get all of this tearing even though you have dry eyes. So using artificial tears without preservative is the best solution for having dry eyes. Use them as much as you want to make your eyes comfortable. Let's go on to the next one. So naturally as we age, we get floaters in our eyes. So these floaters are when the vitreous cells kind of clump together. And what we are actually seeing is a shadow back on the retina. That's what we're seeing, is the shadow of those cells that have clumped together. Floaters are normal. They're not dangerous. They can sometimes be annoying, especially when it floats into the vision that you're trying to read or something and you get this floater. Sometimes by blinking or moving your eyes, you can get it to float away. The only time we ever really do something about floaters is when they are so bad that it is really truly interfering with your eyesight. And then what they do is what they call a vitrectomy, which is taking the vitreous fluid out of the eye and replacing it with something different. So that's only in cases where the floaters are so bad that it's really affecting your eyesight. Now, floaters are different than flashes. Flashes are a whole different story. If you're seeing flashes, you definitely need to go in and see your ophthalmologist, okay? Let's go on to the next one. So another thing that we need to be aware of is this light-dark adaptation. Our eyes don't adjust to that as well as they did when they were younger. So going from the bright sunlight into a building, it takes us a little while longer for our eyes to adjust. So we need to stop, let our eyes adjust for a minute before moving on so we don't run into something or trip or take a tumble. Next slide. With mature eyes, we can also get more glare. So this is like the headlights. When we're driving at night, we might see the headlights. So for glare reduction, what we can do, if you're also getting glare in the daylight, sometimes even in the daylight, this is just a great picture of glare because it's one of the most obvious. But if we go on to the next slide, we can talk about what we can do for glare reduction. So if you're getting a lot of glare, use a visor. Block the light that's coming from above that might be bouncing back. If you're getting light bounce back around you. If you're outside, use your sunglasses. But don't make them the darkest you could trip, okay? But just you want to block the glare and make sure that the UV is blocked to protect your eyes. Working on a computer screen, you might not want to have the computer screen facing the light source. Bring the light source in at an angle. It helps. Position that it's either at the side or behind at an angle, and it will help with that glare that you might be getting on computer screens and things like this. In this picture, a woman is using this little black card to help her read, and that black card is called a typoscope, and it kind of blocks light bounce back that would be coming off of her white page, And the slit in there between her fingers that you can see is where she's reading the line. It also helps with macular degeneration when the lines are wavy to kind of hold your line a little bit, make it easier for you to read. Next slide. One of the things we sometimes struggle with is contrast sensitivity. So this is a picture of like concrete steps. And on the left, you can see the concrete steps, and you can see where the edge is. But if you don't have good vision, the picture on the right, it kind of all blends together. You could very easily take a tumble down these stairs, which could be very, very dangerous. So one of the things that we can do is, like they have done on these wooden stairs, is by putting either a little paint strip on the rise and the step where it comes together so you can see the step going down and coming up both ways. That helps us. You can use concrete paint. You could use duct tape that sticks on almost everything. And it comes in lots of different contrasting colors. But it gives you the edge so that you don't tumble down the stairs. Seeing contrast is important. So go on to the next stage, and I'll show you next slide, and I'll show you a picture of contrast in the house. So if your furniture is a nice tone-on-tone, which is very beautiful, it could be easy to miss the chair in that and end up falling on the ground. So by having contrasting chairs to your floor, showing you where the edges of things are. The thing that would even make this better is if they had a light color arm on a chair. If you know where the arms are, you can always get yourself into the chair without falling. Next slide. So mature eyes need more light. So you might need task lighting, which is better for seeing things like reading than the room light. So the light that comes in from above doesn't have the same kind of intensity as a task light that has an opaque shade pointing the light right at what you need to see. Okay. Most people will like daylight spectrum lighting. It's better for color, seeing true colors. Make sure that you have lighting in stairways. That's very important. Next slide. So an 80-year-old person needs about 3 times more light to read than a person does that is 15 to 20 years old, okay? Light is very important to us. We don't function so well in low light levels, and the quality of the light becomes more important. Some people like to, that need more light will look to maybe LED lights that can be very bright. But just make sure that if you have problems with glare, that you're, watching for light bounce back. If you get it too light, that's not good either. So the trick with lighting is just enough. Not too little, not too much, just enough. And sometimes that comes from playing with your level of light to make sure that you've got what you need so that you can see what you're trying to do. Next slide. Another thing that we might need as we age is some magnification. Not only just reading glasses, but sometimes we'll need like a magnifier. There's many, many different types. The thing that you want to look for is just a good lens. And remember, the stronger the magnifying power is, the smaller diameter the lens is. So people always come and say, well, I want a magnifier that covers a whole page. That is not going to be a very strong magnifier. And usually if you need a magnifier to see the page, you're going to need one that's smaller than that whole page. The exception to that is electronic magnifiers. You can get bigger electronic magnifiers that will cover a page. So the other thing we want to do is make sure that we are not creating problems when we're using a magnifier by hunching over what we're trying to see to get close to it with the magnifier and creating a crink in your neck or problems with your shoulders. So make sure that you're watching your body position. You might want to bring what you're trying to see up closer to you rather than you reaching, bending down over the top of it. Next slide. Okay, simplification. simplifying our lives, getting rid of those things that we might trip on. So I love this little cartoon. It's the evil fairy, the clutter fairy, doing her nightly rounds, because she's always saying 3 weeks after throwing something away, you're going to need it again. But having things around that we are no longer in use, that are stacks of things that are trip hazards. So simplify your environment. Next slide. Organizing your environment. If you have problems seeing, you will want to make sure that you put things back where they go. If you live with other people, try to train them. I know that's harder. Train them to put things back where they go, so you always know where to find something. Next slide. Use defensive walking. So if you're walking in the evening or at night, use light-colored clothing. Scan ahead for hazards. Eyeball drivers when you're crossing the road. Make sure they're seeing you and not on their phone. If you need a cane or mobility device, use it. And stay off the phone while you're walking too, because you may need your attention to make sure that the other people, such as drivers, are also paying attention. Next slide. Okay, so some of the things to consider if we're not seeing so well to help us so that we're not tripping, we're able to do what we need to do, is lighting, contrast, magnification, simplifying things, and organizing them. Next slide. So make sure that you're getting a regular eye exam at least every 2 years. If your insurance pays for a yearly exam, use it. If you have an eye condition, you will want to see your ophthalmologist as often as they suggest, which might be more than every 2 years. Wear glasses. Have them checked regularly. Sometimes our prescription changes. Keep them clean. Smudgy glasses are hard to see through. Get timely cataract surgery. Sometimes we don't realize how bad our vision has become because it's happened so gradually. So make sure that they've checked you for cataracts. They will do timely cataracts. They don't want to do it too early. They don't want them to get too dense. So they call them ripe, which is kind of a weird thing, but they say when the cataracts are ripe. And then making the adaptations when you're negotiating around your home, in the community, to help you with vision loss. And that might be using a cane. That might be using another visual aid. Next slide. Wear sunglasses. Sometimes a visor is really nice also, especially if you get a lot of light sensitivity. Consider in your environment, lighting. Do you have the proper lighting to be doing what you need to do? And contrast. If necessary, low vision services are available to help you increase your functioning. The state of Utah has the Division of Services for the Blind and Visually Impaired. We have a low vision service up here at the Moran Eye Center. And the VA, if you're a veteran, the VA has a low vision service as well. So those things can help you in your functioning. And again, clean your glasses. Smudgy glasses, hard to see through, you can trip. So I think that is my last slide. I think maybe, yeah, any questions? And you'll have to read the chat off to me or the questions because I'm not getting that.
Anybody has questions?
Okay, I must have done a good job, I think, huh?
Yes. Yeah. Okay. Oh, here's a question in the chat. It says, maybe. Oh.
Can I ask a question? Oh, this is Melissa. Do the computer, like the glasses for computers, the ones that have like a yellow tint to them, maybe, do they actually help? Are they effective in managing eye fatigue and dry eye and tiredness and all of that?
Yes, using that
Great.
20-20-20 rule when you're using the computer is really important. Some people really say that they've noticed a difference with the blue blocking glasses that blocks that blue light wave that's coming from computer screens, and they think that also helps them. It really becomes one of those personal kind of things. Some people say yes, definitely. Other people say not so much. So.
Okay. Thank you. I've always wondered about that.
Yeah. Well, I'm up at the Moran. If you have any questions, you can always find me here.
Great. Thank you so much, Lisa, for doing this, and Melissa too. So
Does she have an email we can write down?
yes, I
Lisa,
put it up.
yeah, .org@HSC. Here, I'll write it in the chat. How about that? I can write it in the chat.
I have a question.
There you go.
Yes, Monica, go ahead. Do you have a question?
I was asking Carol if she had a question.
Oh, it's kind of hard to verbalize. I do have dry eye, and I'm always looking for something that might help. But so you say that just plain tears without any fancy things.
Right. What you're looking for is something, a product that says natural tears and no preservatives. Stay away from the preservatives. They will irritate your eyes even more.
Okay. Thank you.
Lisa and Melissa, we want to thank you again for being here today, for your time and all that wonderful information that you've shared with us.
Happy to.
We see their contact information is on the screen.
Yes.
So if anybody wants to follow up with them after this presentation.
Yeah. And also feel free to give them my slides. I don't know if you usually do that, but I kind of designed them to be a handout for patients too, for a reference. So.
Yeah, we can do that.
Okay, perfect.
Yes, thank you.
You're welcome.
And then just before all of you go, I just want to show you the next webinars that we have coming up. October 6th, we have a safety and prevention for COVID. She's going to give us more information that has to do with COVID. But this one is actually going to be reliable information coming from Salt Lake County Health Department. And there is the dates every Tuesday at 2 o'clock. And the fourth Tuesday of every month, we have one in Spanish. Other classes that are coming up, we have Living Well with Diabetes. That's going to start on Monday, October 5th from 10 to 12:30, or Living Well with Chronic Pain. That one starts on Thursday, October 8th from 1 to 3:30. If you guys want to register for any of these classes, you're welcome to reach to myself, Erica, Paige, Monica, or Marianne, and we can get you signed up. Another few more classes. Walk with Ease is going to start September 30th. What? Tomorrow? So you guys better sign up for it at 10:30. Oh, different schedules. So September 30th, Wednesdays at 10:30, October 25th, Mondays at 11, and Paige, she can answer all your questions. We also have cardio, strength, and stretch. And that one starts September 28th at 9. And those are all the classes that we have. We thank you so much for coming. I hope that you guys enjoy this presentation, and thank you so much for your time.